Hello, I'm Bridget Byrne, and for those of you who weren't here yesterday, I just want to introduce myself and the Centre on the Dynamics of Ethnicity Code. So I'm based at the University of Manchester and I'm the Director of Code, and I'm very pleased to welcome you to this second event of the 4-day conference that's organised in partnership with the Stuart Hall Foundation and the Runnymede Trust on racial inequality in a time of crisis. First, I want to tell you a little bit about CODE. The Centre on the Dynamics of Ethnicity is a research centre based at the University of Manchester, but bringing together colleagues from 10 universities across the UK. Our current research programme, looking at COVID, race and ethnic inequalities, seeks to provide a rapid response to the crisis posed by COVID-19 and its social, cultural and economic impact on racial and ethnic minorities. We're a multidisciplinary team using a range of different methods and seeking to provide robust evidence on the often lethal impact of racial and ethnic discrimination and inequality. We aim to provide new data in accessible formats to champion policy and institutional change by showing where and how racial inequality is present, how it builds on and extends existing patterns of inequality, and how this is experienced in everyday lives. We've launched what we hope will be the largest survey of its kind of ethnic, racial and religious minorities and how they've been impacted by the pandemic. This survey is called EVENS, the Evidence for Equality National Survey, and I'd encourage you to fill it in. I think there'll be information at the end of the seminar. We're very clear that the impact of racial and ethnic discrimination and disadvantage are not one-off events, but processes that happen across the life course and across all aspects of lives and individuals and communities. We want to understand those processes, but also working with a range of partners, we want to think about how communities are challenging discrimination and disadvantage, particularly in the wake of Black Lives Matter. We're really pleased to have this partnership with Stuart Hall Foundation. We take on Stuart Hall's call for the aim of academic research on race and racism to be to change the world by challenging racial injustice and discrimination. We've also collaborated with the Stuart Hall Foundation and the Holick Family Foundation on the Stuart Hall Race Report, which was brought out in February of this year, which summarises the policy recommendations that have been presented over the last 40 years of tackling racial inequality in Britain. We know the problems, we know some of the solutions, and it's time for a change. So I'm really pleased that today's session is focused on health and well-being. Perhaps of all the ways in which ethnic minority people have been affected by the pandemic, health is the most high profile. The disproportionate deaths among ethnic minority people has been impossible for even the mainstream media and politicians to ignore. However, it's important to track the reasons behind that high death toll. The health inequalities produced by discrimination and disadvantage, as well as the ways in which inequality in education, employment, housing, access to healthcare have made racialised groups more vulnerable to the impacts of the virus and the lockdowns and restrictions that have gone with them. So that's why I think this panel is so important. I hope you find it informative. Please follow CODE's work on Twitter, Instagram and the web, and consider attending the other events in the week-long conference. Tomorrow is on employment and young people, Friday on culture and cultural activism. But now I'd like to hand over to Dharmi Kapadia, who's going to introduce and chair the event. Thank you.
Hi everyone, and welcome to the second day of Stuart Hall Foundation's week-long online conference, Racial Inequality in a Time of Crisis. As Bridget said, I'm Dharmi Kapadia and I also work at the University of Manchester as a lecturer in sociology, and I'm also a member of CODE, and I'll be chairing today's event. In today's event, we'll be critically discussing the health and well-being of ethnic minority people in the UK, and we've got a fantastic lineup for you. Professor James Nazroo from the University of Manchester and CODE, Natalie Creary from Black Thrive, and Dr. Parth Patel from the Institute of Public Policy Research and University College London. If Natalie and Parth could just come onto screen just so that our audience can see the speakers. Oops, maybe they can't do that just at this minute, but you'll be seeing them very shortly anyway. So we'll be hearing from our speakers about how ethnic minority people's health has been disproportionately affected by the pandemic, why this is the case, and how ethnic minority groups, activists and community organisations have responded to the crisis, and what needs to be done in the future to eradicate ethnic health inequalities. Before I go on to introduce our speakers, for those of you who are on social media, Twitter or Instagram, please use the hashtags COVID Inequality UK and Stuart Hall Foundation to tag your posts so that our social media team can retweet or repost your thoughts on the event. And tonight, just to remind you of the structure of the event, each of our speakers will speak for about 10 minutes, and then I'll chair a discussion with the speakers for about 20 to 30 minutes. And following that, we'll have about 20 minutes for questions from the audience. So if you could please use the Q&A box in Zoom to post your question to the speakers, that'd be great. And we'll be keeping an eye on that box. The chat function is also open for more general comments from the audience, and for us as the speaker panel and Stuart Hall Foundation to post relevant links to you that come out of the speakers' talks. So do please keep an eye on that chat box too for links to works done by the speakers. So our first speaker tonight is James Nazroo. He's Professor of Sociology at the University of Manchester and Deputy Director of CODE. He's also my colleague. He's co-director of the Synergy Collaborative Centre, which is investigating ethnic inequalities in severe mental illness, and also co-director of the Manchester Institute for Collaborative Research on Ageing, on MICRA. James's work on ethnicity and race has focused on developing an understanding of the links between racism, socioeconomic inequalities and health. And he's also part of the team at CODE, along with myself, that is undertaking the survey that Bridget mentioned, the Evidence for Equality National Survey, or EVENS, which is Britain's largest survey of ethnic and religious minority people, which has the aim of understanding and documenting how these groups have been affected during the pandemic. So welcome to James, and I'll hand over to him now.
Thank you very much, Dharmi, for the introduction, and thanks also to the Stuart Hall Foundation for hosting this set of events. The partnership, as Bridget said, is really important and something that we hope we can use to good effect, both the Stuart Hall Foundation and CODE. So a few logos on my introductory slide, which I just want to point to. The two important ones are on the left, of course, CODE, which you hopefully know about and hopefully will learn more about over these events. But also the bottom left, you'll get tired of hearing of this during this session and maybe other sessions, the EVENS study, which I'll talk a little bit about, or at least I'll put a slide up. I won't talk about at the end of my talk, and we'll hear more about it at the end of the session. You might get tired of it by the end, as I say, but please do take part and do publicize it. Crucially important study. As you can see from the title of my slide, I'm going to be talking about how...
I'm really sorry to interrupt you, but would you mind taking your headphones out?
Yeah, I do that. It's not working.
Yeah, just so it's a bit easier for our audience to hear. Thank you very much.
Hopefully that's better. Thanks, Dharmi. Hopefully that's clearer for everybody. So, starting point, I guess, is that health inequalities has been a focus of the work of CODE for many years and continues to be a core focus of the work of CODE. We kind of study a whole range of things, going from people's reports of their general health through to, as Dharmi mentioned, severe mental illness. Throughout, the focus is on inequality. What is shaping ethnic inequalities in relation to health outcomes? And we've taken the same approach, of course, to understanding what's happening in relation to COVID-19. And central to that, as you can see from the title of my talk, is understanding the ways in which racism shapes these inequalities. Now, just to remind you, the inequalities in relation to COVID-19 mortality are very large. If I can get my slides to move on. Yeah, they're very, very large. So you may well have seen a graph like this before. You've certainly seen the media coverage of this, and you've seen government talk about it, and so on. To give you a sense of how large this is, when I started my work on ethnic inequalities in health in the early to mid 1990s, there was a huge public health focus, health promotion campaigns around the higher risk for South Asian people to die from heart disease. That higher risk was somewhere between 1.3 and 1.4 times higher. If you look at 1.3 and 1.4 times higher on this graph, you can see that almost all of those bars are higher than 1.3 or 1.4 times higher than the white rate. The axis on the left-hand side is measuring how much higher than the white rate the risk of death is from COVID-19 related conditions. I put up slides every now and again that shock me, and I put them up again and they shock me again, and I put them up again and they shock me. This slide, every time I put it up, it shocks me. The height of those bars is astounding. We've also seen the kind of discussions around maternal mortality. These figures, some of these figures are comparable to that. So shockingly high rates of mortality, cutting across almost all ethnic groups here. The female Chinese group is the only one that is not statistically significantly different. An approach by government in a number of ways, but in a number of ways that I will argue distract from the focus on racism and the ways in which racism shapes these inequalities. So how do we set about trying to understand these inequalities? And the top 5 bullet points are the framing that we get for the inequalities from a range of scientists, a range of public health officials, and from government and chief spokespeople. Discussions around economic inequality, the social and economic inequalities that are faced by ethnic minority people across a range of domains make them vulnerable to poor health. If you remember the initial reporting of these high rates of mortality from COVID-19, you'll remember the surprise that people had, not the shock, the surprise that people had in relation to these. These socioeconomic conditions have been shaping a whole range of health outcomes for ethnic minority people. We knew about this before the COVID-19 pandemic. The COVID-19 pandemic just reflected what we already knew, what we'd already seen. Why were people surprised to see this? Why were people not paying attention to ethnic inequalities in health? And as I said, I'll argue, why are these ethnic inequalities in COVID-19 related mortality not really engaged with? Other things that are talked about, of course, are risk of exposure to the virus because of employment conditions, but particularly the focus and the policy focus has been on the remaining 3 things that I have in those 5 bullet points. So much of the research activity and much of the policy focus has been on underlying comorbidities, the fact that poor health makes you vulnerable to mortality from COVID-19, not the fact that your socioeconomic conditions make you vulnerable to poor health, which then makes you vulnerable to COVID-19, or that there might be some genetic stuff going on. Lots of research trying to explore the genetics of COVID-19, of the greater mortality risk amongst ethnic minority people, or cultural vulnerability. And again, lots of focus on this, gatherings in mosques, gatherings in synagogues, and living in multi-generational households. So the focus shifts to one on the properties of individuals within particular ethnic groups rather than on the conditions in which they live. So I argue that we need to think completely differently and in fact move away from this list of 5 explanations, including the first part of that, and begin to think about how racism shapes the risks that ethnic minority people face in terms of health outcomes. And that means a focus on the processes that lead to the racialization of ethnic minority groups and religious minority groups and the consequences of that. I've been encouraged to look at the work of Leon Marshall, who does a number of videoed public lectures. And I watched one the other day, and one of the things he said was that when you talk to people, when you talk to politicians, when you talk to officials, they say, "I don't see racism. I don't see racism." This is the kind of Piers Morgan approach. I don't see racism. The public health response has been to ignore racism or discussions of racism have been suppressed, government response has been to say, racism isn't important. I don't see racism. And so I'm now going to try and show you how and why racism is important in shaping health risks. And I'm going to do that by talking about structural racism, interpersonal racism, and institutional racism, as you can see from this slide. So this is the kind of rubric that I use to approach the relationship between racism and health. Structural racism is reflected in the disadvantaged access to economic, physical, and social resources, the kind of things in the first bullet point that I showed, but going beyond that to a broader set of physical and social resources as well. There are deep and persistent inequalities in these factors, and there has been little change across generations and across periods. Little change in these things. So we've seen mobility in terms of education, but the consequences of that mobility have not translated into improved economic conditions. Persistent inequality across generations, across periods. And importantly, this isn't just a material impact on the bodies of individuals. It also has cultural and ideological dimensions. We have to be able to justify this material inequality, and we do that by denigrating others. So it's the denigration of ethnic minority people that goes alongside this material inequality. And the resulting level of disadvantage, the way it accumulates across a life course, makes a substantial contribution to ethnic inequalities in health outcomes. You will see analyses that say economics is not that important, it only explains a little bit, but that's because those analyses don't properly measure the depth of the inequality and the way in which that inequality accumulates across a life course. And I'll say something about that shortly. The second thing is interpersonal racism. So this ranges, as we know from the everyday slights, being ignored, being served late, and so on, through to active discrimination, through to very active aggression. It's a form of violence that devalues our identities, makes us insecure in our environment, and makes us insecure even if we're not directly targeted by racism. People like us are being targeted. This then consequently generates meaningful stress that impacts on our biology, that impacts on our health. And evidence suggests that there's been little change in the prevalence of racism or prejudice over the past 3 decades. And I'll give you just a snapshot of that here from a number of studies. The top line shows levels of prejudice ranging from the hostility of the 1980s, when the National Front were active, through multiculturalism, through to anti-immigration hostility. And over this whole period, you see an almost consistent level of reporting of prejudice amongst the general population of Britain. And then the other slides show, the other lines, sorry, show fear of racism, the 2 dotted lines, and experiences of racism measured over a shorter period. And apart from the decline in experiences of racism for Irish people, the grey line, you can see a persistence of experiences of racism from the early 1990s through to the late 2010s, with some rises, of course, in relation to Pakistani people who've experienced increases in Islamophobia. Institutional racism. We know the definition of institutional racism, of course, the routine procedures and practices that harm the lives of ethnic minority people as they come into contact with institutions. This is not just unconscious action, of course, this is conscious action, conscious action and conscious rule following, procedure following, that then impacts on the lives of ethnic minorities. I want to show you 2 photos just to illustrate the point. 2 photos from a study that we did around the experiences of severe mental illness, the lives of people experiencing severe mental illness. This first photo, the photos are both from the same person. The first photo, the person says, the picture with the wonderful sunset in the boardroom is in the buildings where I speak about my experiences as being a service user and how things can change. He's invited into situations where he can talk about his experiences and try and influence policy in relation to that. He then leaves the building. And then when I come down, I'm stopped by the police as my car has a log on it on the system stating I'm a forensic mental health patient. So a man who is used to provide support and advice and credibility, and then is stopped as he leaves. And How does this reflect institutional racism? Well, we can see the obvious ways it does, but crucially here also is the fact that he is a forensic mental health patient. Why is he a forensic mental health patient? Why is he on the log? And how does his race and racism place him in that position is something that we need to carefully examine. So what does this mean for something like COVID-19, which is an age-related condition? We know that the vast majority of people who die from COVID-19 are in older ages. And I talked about the accumulation of disadvantage across the life course. So we can think about the ways in which institutional racism, interpersonal racism, and structural racism and the disadvantage they bring accumulate across the life course, impact on our biology, which means that our biological age is not the same as our chronological age. And that's what this chart attempts to show. So it shows the proportion of people who say their health is poor, from young ages to older ages, left to right. You can see it rising. You can see different ethnic groups in the different colored lines, but you can see the divergence as we move into middle age and then into older age, with ethnic minority people having much higher rates of poor health. And the red-orange line that goes across the graph just shows the different, just look at the different ages at which the different ethnic groups cross that line. So this is a line that the white groups cross in their mid-60s, that the Indian and Caribbean group cross in their late 40s, that the Pakistani group cross in their late 30s, and that the Bangladeshi group cross in their early 30s. That shows the difference in the biological aging that happens across different ethnic groups, which then results in premature mortality in relation to an age-related condition like COVID-19. We've known this for a long time. It's not a surprise. Why was nothing done about it? And so I'm going to conclude with a few comments, but while I do so, I'll just put up that advertising slide for the EVEN study. Have a quick glance at what we've got there, jot down the contact details, and do encourage people to take part as well as take part yourself. My concluding comments are: structural racism, interpersonal racism impact directly on the health of ethnic minority people, increase their vulnerability to poor health, increase their vulnerability to age-related conditions. Institutional racism aggravates that. It's the point at which these things come together and disadvantage is amplified. Institutional racism operating across a whole set of institutions that shape our life chances. In terms of a policy response to COVID-19, we need to talk about racism, but then we need to think about how we can act on racism. And obviously acting on structural racism and interpersonal racism is a long agenda that we should start, that we need to start, that we haven't started, that we should have started 50 years ago. But we can now work on institutions. We can think about vaccine rollout. Why has vaccine rollout happened in the way it has? Why has it ignored the needs of those who are aging biologically sooner? Why has it ignored ethnic minority people as a priority? Why were vaccine rollouts done in particular ways that were distant from communities when they started, at the point at which the most vulnerable were vaccinated? And that's just one example of the ways in which we can think about how our institutions amplify inequality that could be shifted to redress inequality. Okay, thank you very much. That's it from me.
Thanks very much, James. That was that's really a lot of food for thought for us as we're going into kind of the next speakers, and also for our audience to mull over. Remember, if you've got any questions,
I can't hear you.
Ooh. Can you hear me now? Okay. Okay, I can be heard. I've just seen that. Yeah, so sorry, I was just going to say, if you have got any questions for James, please remember to type them in the Q&A box in Zoom, and we'll collate these questions and put them to the panel towards the end of the conference. So next up, our second speaker, we have Natalie Creary, Programme Delivery Director for Black Thrive. For those of you who don't know, Black Thrive is a cross-sector partnership working to address the structural racism and inequalities within mental health systems that affects Black African and Black Caribbean groups. And Black Thrive really aims to centre the voices of these communities to influence policy and embed anti-racist practice within research and statutory services. So I, for one, I'm really keen to hear, as I'm sure our audience is, Natalie's perspective on how the group she's working with have been affected by the pandemic and the important work that Black Thrive have been doing during the crisis. Over to you, Natalie.
Thank you. I'm just going to share my screen. Okay. Brilliant. So I think James has sort of touched on sort of like quite a lot of things around kind of the health outcomes for communities, for people from Black, Asian and minority ethnic communities. And as he mentioned, sort of due to structural racism and other barriers, Black and brown bodies are kind of disproportionately excluded, neglected, restrained, and have their liberty removed from them. And we see this in the way in which powers such as the use of the Mental Health Act are disproportionately used against Black bodies. So we're more likely to be detained under the Mental Health Act. We also have a higher prevalence of long-term conditions and premature mortality. And when we look at the links between mental health and physical health, much of the inequalities that we see are avoidable if we take action on the social determinants of health. And what we see, in particular in our work that we're doing in Lambeth, is that Black communities, we've been pulling data from different parts of the system, and it shows that Black communities experience quite significant inequalities across all social domains of their lives, basically. And so we see that structural racism is limiting their lives across the life course. So during the COVID-19 pandemic, what we noticed was that kind of people from the Black community were saying, hang on, something is happening here. Like this virus is disproportionately impacting our communities. And what we found was that actually their voices were ignored. And so what we did was we trained people who were rooted in the community as researchers to help us have an understanding of how the first lockdown was impacting their well-being and just generally trying to find out what is going on for them. And it was really interesting that we kind of managed to surface that information really quite quickly. So I think within 2 weeks, we had about 400 responses. And what was really quite interesting from that was that we managed to surface this information far more swiftly than the statutory system. And it was much later on, once they decided to get their data together, that they realised, oh, something was happening. So I think there's really something about what we should be learning from that, is that when communities are speaking, it's really important for systems to listen, because if we were acting sooner, we may have been able to minimise the impact that the pandemic has had on our communities. But even within that, we also noticed that the system was reluctant to acknowledge the role of racism. And we can see that even in the inquiry into the disproportionate impact of COVID on minoritized communities. And it was, even though I was part of those conversations where people were kind of very, very kind of loud about the role of systemic racism, and yet when you saw the report, it was like they kind of mentioned it, but it wasn't part of any of the recommendations. And then when we think about some of like the economic fallout from the pandemic, again, for Black communities, it was really quite significant. So we know that young Black men have been disproportionately impacted in terms of losing their jobs. And prior to the pandemic, Black communities experienced significant barriers to securing and sustaining good work. And so this is likely to be exacerbated as the competition for jobs increases. And so these are some of the things that we really really need to start to think about. And we did another piece of research trying to look at the experiences of Black people who were living with long-term conditions in terms of how they're able to access and sustain good work. And what was really quite interesting for people who are in work, they found that sort of systems that were supposed to support them, like the occupational health system, was actually used in a punitive way that kind of forced people out of work. So these are some of the sort of, when we think about like how racism operates within systems, these are kind of some of the examples of the challenges that Black people who are able to work, who want to work, are prohibited from being able to do that. There was obviously there were the impact in terms of the physical impact we've seen from, you know, what was presented by James earlier, that actually the virus disproportionately impacted Black people. And, you know, as a consequence, we also saw high levels of people who were dying as a result of the virus too. And so this has inevitably had an impact on levels of bereavement within the community. Other kinds of experiences of trauma also include kind of the over-policing. So we've seen that like Black bodies, again, are being disproportionately stopped and searched, not able to go and get food from the shop without being harassed. And in our survey, that was one of the things that came through, that people were reporting that actually they didn't really feel comfortable going to get basic necessities because they didn't want to have those interactions with the police. Some of the other things that we also need to be sort of thinking about was also the impact of kind of social distancing and the disruption that has caused to kind of community connections and networks. And although we've been able to move a lot of things online, there are people who are digitally excluded. And so this has also had kind of huge impacts in terms of just even people engaging in our work. You know, we've had kind of community researchers working with us, and we're thinking, why is it taking so long, you know, for them to like get back and to report on a document? And then you find out that they're actually trying to kind of comment on huge spreadsheets on a mobile phone. So, you know, these are some of the things that people may not necessarily be, you know, may not necessarily actually bring to your attention when you're trying to kind of work with them in a collaborative way. And I think broadly, there has just been a general lack of culturally appropriate or culturally relevant services. And so again, we've been working with people in the community and with our local mental health alliance to co-design a peer support and advocacy service that centres the voices and experiences of Black people. My next slide. So I guess for me, when I'm thinking about what needs to change, I'm really tired of us like describing the problem and in terms of like the outcome, I guess, that we see for Black communities. I think for us to move forward, we need to recognise racism as a public health issue, and that has been something that the American Association for Public Health Association, you know, they kind of made a statement that, you know, racism is a public health issue. And we've seen that within the public health literature that racism, they're completely silent on it. And so it's really important that we start to understand and explain the consequences of racism and how that is linked to the inequalities that we observe. And again, we have been working with people in the system who are data holders to ask them to provide an explanation as to why they see the inequalities within their service. And one of the things that we have noticed is that the explanations provided reinforce racial stereotypes. They generally locate the problem or the challenge within communities or individuals. So it's about Black people's action or inaction. So there is a real need to develop the workforce's understanding of inequalities in the context of systems of oppression. It's so important that we start to think about systems change, but within that embedding a race equity lens on that work. Simple things that we can be doing is around kind of collecting inequalities data and obviously acting on it. One of our biggest bugbears at the moment is the Department for Work and Pensions maybe collecting it, but they certainly don't publish information across the protected characteristics. So again, it makes it very difficult to understand where the opportunities and challenges lie. And I think what's really key is that we listen deeply and create opportunities for marginalised communities to be centre stage. And I say that because we often have a lot of people talking on our behalf and advocating on our behalf. And I think it's really important that we are at the forefront of conversations about us. And when we're thinking about the knowledge production process, that we ensure that that's an equitable process. So I often kind of complain that when we're thinking about the evidence base, that actually Black people are either hypervisible or invisible. But what often happens, although like now everybody wants to be, you know, at the forefront of kind of research on racism, that actually we aren't the experts in our experience, although we kind of are, but by the nature of the knowledge production process, it means that other people are still telling our story. And so what I think is really important is for us to ensure that, you know, Black people are able to tell their stories, but remain the expert. And ways of doing this is also about how you invest and resource Black communities to deliver solutions for themselves. Because again, if we're trying to think about a broader approach of how we address inequalities, we need to think about the benefits or how we reap benefits beyond the beneficiaries, so that we're actually thinking about our interventions again from a structural perspective. So where are the resource flow, you know, where are the resource flowing, you know, how are these policies really kind of coming from an anti-racist perspective? And I think if we're able to do that, then we are more likely to be able to play our role in reducing some of the structural barriers that currently confront us.
That's brilliant, Natalie. Thank you very much. Yeah, we'll be picking up some of the points that Natalie has discussed in relation to the work that communities are doing themselves and what needs to happen for that work to continue in the discussion. But remember, if you do have any questions for Natalie, please pop them in the Q&A box, and we'll pick those up and discuss them in the section at the end. So our final speaker tonight is Dr. Parth Patel. He's a research fellow at the Institute for Public Policy Research, IPPR, and University College London, UCL. Parth also works as a doctor in accident and emergency, and he's interested in the political economy of health, with much of his research focused on understanding how migration and ethnicity determine health outcomes. So I'm really interested to hear Parth's take on the government response to COVID and how these kinds of decisions have played out for ethnic minority groups. So welcome, Parth, and over to you.
Thanks, Dharmi. Hopefully that's come up for everyone. So I think what I'm sort of going to reflect on is really policy making in the past year since sort of the COVID crisis began, and building really on some of the stuff that James and Natalie have been saying about the evidence, and really looking at how that evidence interacts with politics, ideology, and practicality to then develop into policy. So I won't dwell too long on this slide because James went through it very thoroughly and very well. But it's really the big hammer home point is that the only thing that's surprising about race or ethnic disparities in COVID-19 mortality is how big they are. They're really some of the starkest inequalities, health inequalities in recent decades. And I've written this extra comment of questions around causality dominate the discourse. I think that's quite an interesting point. So let me just come back to that. So if you look at the slide, the diagram on the left is a really, really simple take on how racism can interact with health. It's sort of a very dummy version of the stuff that James was doing. But broadly speaking, there are sort of two pathways. It's sort of it's the traditional social determinants of health, where you live, what jobs you do, how much money you have, all that stuff determines your health, and racism determines all those things. And then there's also this other way that racism interacts with health: experience of discrimination, stress, access to institutions, all those things determine your health too. And the reason I bring that up is sort of this big figure in the middle. This is from the ONS, and it's quite standard approach. It's sort of looking at the interaction, the association between ethnicity and COVID-19 outcomes. And you toss up the numbers and you adjust for differences in age structures between populations, and you see this big number. Wow, sort of 3-4 times risk disparity between people from Black African backgrounds and people from the white ethnic group. And then you start to adjust for things. It's quite common in epidemiology to sort of statistically adjust for various things, like where people live, how deprived they are, what jobs they do. Sort of those things are called statistical confounders, and it sort of brings your risk disparity down to still quite sizable levels, sort of 2 times the risk. And then that's the figure that's quoted. All the other stuff is sort of forgotten, as if that had nothing to do with race. So you take out deprivation, you take out occupation, you take out household conditions, and then you're still left with stuff. And that stuff you're left with is how race interacts with health, where actually that's not quite true. That big number you started off with is an example of how structural racism interacts with health. And I think it's just quite important to make sure we are aware of those things. They're not statistical confounders, and they shouldn't be forgotten. This sort of diagram, very simple diagram on the right, is just a very rough take of how exposure to the virus differs between different ethnic groups, how that then leads to different outcomes in terms of the COVID disease you suffer with itself, and then what the fallout of that is. And in grey, I've just labeled some of the things that mediate those steps. Differences in what jobs people do, essential workers, public-facing jobs, job security, 0-hour contracts, having sick pay, how overcrowded your housing is. When I say contacts, I mean sort of how many people you interact with on your day-to-day life. Do you have to use the bus, for example? Differences in wealth. All those things are really going to determine your risk of exposure to the SARS-2, which is the virus that causes COVID-19. Sorry, I should have been a bit clearer. So you might think those are quite obvious policy targets if you were keen to address these really massive disparities between ethnic groups, but it's not quite that simple. So evidence isn't neutral. Evidence has to be interpreted, and it's always interpreted through a particular ideology. And what I'm sort of trying to draw out here is 2 different ways that the same bit of evidence can lead to really quite different types of policy. So let's start with just a really broad statement. People from all minority ethnic communities are more likely to die from COVID-19. That's evidence. It's fact. It's objective. But then what does that mean? How does that become policy? What do you do about that? The top half of the diagram is sort of an individualistic ideological lens, and the bottom is sort of more structural determinist ideological lens. So let's start on the top one, individualism. How does that affect? So if you had that sort of ideology about individuality, you might then read that and think, okay, what I need to do to address this is tailor my information, change the information I'm giving people, change the communications approach, so that then people then have the freedom to act responsibly. If I change the information available, people will then act more responsibly. And that leads to some of the policies on the right. Whereas at the bottom, if you took a more sort of structural approach to what could be going on here, so people from all minority ethnic backgrounds are more likely to die from COVID-19. That's quite a systematic difference. So maybe that's related to systematic differences in housing, what people live, what sort of jobs people do. That then changes your policy targets. You then think, instead of, you start thinking about, okay, so what can I do to give people the capability to act, to protect their health? Instead of providing more information, you think about providing the means to act on that information. And that leads to quite different policy. And again, the point here is you start from the same evidence and you end up with quite different policies. So just scanning some of those right at the top, again, so back on the top half of that diagram, is translating public health advice. Yeah, that's happened. Celebrity campaigns, again, that's referring specifically to vaccines. I should have, again, been a bit clearer there. But there's been quite a lot of sort of Bollywood-based campaigns, for example, to help people take the vaccine. Personalized risk assessments, again, something we've seen. Whereas if you do a more structural approach, you might end up with different policy. You might end up with community isolation facilities, that, for example, using empty hotels during the pandemic as places in which people can isolate in safely. Newham Council have started doing that very, very recently, and they're the first place in the country to do it, but arguably too late. Sick pay, it's astounding to me how we've gone through really a year of a pandemic without addressing the sick pay issue in the UK. It's one of the lowest rates in Europe. It's not just a matter of social or racial justice in a pandemic, it's purely a public health hazard that people who may have COVID-19 feel that they have to go to work because they're not going to be able to get by on the amount of money they get paid on sick pay, if they have that at all. And vaccine prioritization and delivery, and James mentioned this, and I suspect this might be something we come back into the discussion, so I won't dwell on it too much, but sort of how we go about the vaccination program and thinking about how we address that is again something that could lead to something quite different. So I guess that's me just pointing out here how sort of politics precedes policy, and the way you interpret the same bit of evidence leads to vastly different interventions. And in terms of what we've seen in real life, we've seen a lot more of the stuff at the top and a lot less of the stuff at the bottom. And to be honest, I should be clear here that it's not either or. You don't pick one approach. You say, I'm just going to do this one. In an ideal world, you would do a mixture of both. There's not sort of personal responsibility versus complete determinism. It's always a mix of both, is what you would like to do in an ideal world. So, sorry, I've lost this slide in my title. Okay, and yeah, so this slide is sort of flipping some of that, sort of that almost that diagrammatic approach into actually what's been happening. And really the difficulty in acknowledging the role racism plays in racial health inequalities leads to this debate, this relatively unproductive debate that then distracts us from what's happening on the ground. And what's happening on the ground is really not that much, at least not that much of the stuff that allows or gives people the capabilities to act in a pandemic, to protect their health and to protect their families. On the left here, sort of, you can see some of the stuff that's happened. You've got a quarterly report from the government that said that these outcomes aren't related to racism, disparities aren't got nothing to do with race. You've got a censored Public Health England report that was gutted and then replaced and edited. You've got an advisor pulled in that doesn't have a background in race, advising the government on race. And you've got this more recent trend of sort of columnists in places like the Daily Mail saying people have to have the vaccine and they should be forced to have a vaccine because they're killing people. And by being hesitant, they're killing people. Sort of, again, that's something we should probably come back to, because I'm not really sold that disparities in vaccine coverage, which is about rates of people actually getting vaccine, have that much to do with disparities in vaccine attitudes. And what is ignored is structural differences in how people access vaccines. And then you've got these sort of people on the right, well, they're on the right in this slide, but most of them are on the left in real life, about sort of some of the stuff that they would like to see happen to address structural inequalities or racial disparities in COVID-19. There's a report I led for a joint report from the IPPR and the Runnymede Trust that called for a set of actions, included things like, for example, hotels as isolation facilities. You've got the government's own scientific advisors that sit on SAGE, writing an editorial in Lancet endorsing some of those policies. You've got a great review from Baroness Doreen Lawrence, and you've got some bolder thinking from people like Halima Begum at the Runnymede Trust, who's sort of saying, well, door-to-door vaccinations might help address this. And that is a policy that, unsurprisingly, was very, very, very unpopularly received in UK politics. So what lies ahead on the hard road to renewal for addressing racial disparities in health? I borrowed a phrase from Stuart Hall and applied a health take to it. My reflections are broadly these two. I think first is recalibrating the starting point. There's a few things here about sort of, James mentioned it, sort of genetics and vitamin D in it. But the problem isn't so much that there's people consider them. The problem, I think, is that the instant reflex in people's mind, mental reflex, is that this is something to do with genetics, this is something to do with vitamin D. And that just is a bizarre starting point, given that there's almost no rationale, theoretical or based on previous evidence, as to why that should be your starting point. It's very, 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 very unlikely. So then a disproportionate amount of effort and funding and research then goes into considering these almost whack theories that are then unproductive because they don't do anything for the real causes of what's driving these disparities. Some of the stuff in that first slide. Public attitudes is another thing. Sort of there's recent work from Bobby Duffy's team at King's, which showed sort of how the public views ethnic or racial disparities and how that interacts with views of meritocracy. And that leads into actually, I think, on to this second point here about race and class, which are systemic oppressions with different roots, but shared solutions. And they're not all the same, but what I'm getting at here on this one is sort of, right now, most minority ethnic people can't be working class. You're either black or you're working class, whereas you can be black and working class, and often more so than not, that is true. And the reasons for aligning some of those sort of regimes of inequality is because they share solutions. And to achieve progress in terms of racial justice or in terms of social justice, there is value in being aligned on that sense. I don't know if I'm out of time or not, but actually I wanted to just give a quick anecdote on this vitamin D thing, just showing how pervasive the problem is. It's not just something that academics debate and the newspapers cover. It's something that happens in real life. One of the A&E departments I work at has a clinical policy that anyone that comes into A&E of a minority ethnic background with suspected COVID-19 gets a shot of vitamin D, which is A, completely evidenced, and B, when questioned upon, the rationale given is that because it doesn't seem like there are many people in Africa dying of COVID-19, whereas black people in the UK are, the difference must be to do with sunshine and vitamin D. So that's what I mean by recalibrating that starting point and engaging more in public attitudes. Right, I'll stop there and look forward to the discussion.
Thank you very much, Parth, for your presentation as well. And thank you to the whole panel for their very well explained, detailed and interesting talks. If I could just ask Natalie and James to unmute themselves and come back onto the screen so that we can start the discussion. So, I mean, I wrote down lots of questions to ask you, but I won't ask you too many because I want to also field quite a few questions from the audience. I think, is Natalie there as well?
Yeah. I am, yes.
Yeah.
Sorry, it's just my screen is a bit smaller. So, I mean, you all touched on the structural, institutional and individual or interpersonal racism that people face and how this really does, you know, this is one of the main causes of health inequalities, poor health, poor mental health for ethnic minority people. And given, you know, that these ethnic inequalities have come to light for some people, many of us knew that they were already there. Do you think that systems, so government, institutions, organisations, do you think they're any more likely now to centre racism within their practices, their policies, particularly in relation to health and mental health? So I'll come to James first because I know that you're a member of the newly established NHS Race and Health Observatory. So if you could maybe answer the questions, but also talk about that newly formed organisation as well, please.
Yeah, and apologies, I've had to revert back to my microphone headset because I can't hear otherwise. So hopefully I'll talk a bit slowly and hopefully people can hear me without too much interference. Yeah, so I guess we're at a point where COVID-19, together with Black Lives Matter, and the set of things that are going on around there, the set of things that we suddenly become very aware of, like what happened to Meghan Markle and Piers Morgan's response to that, opens up a potential opportunity for us to talk about racism in very open ways with an attempt to find solutions. There is that opportunity. At the same time, we have an equalities minister who denies racism. The scientific advisor that she appointed, that Parth mentioned, says there's no evidence for racism impacting on people's health in relation to COVID. And he's a person with no expertise in the field, I should point out as well. And the government inquiry into Inquiry Commission into ethnic disparities has shifted its focus from one on ethnicity, race and racism to one on social mobility. So we have a central government resistance in the context of the opportunity for other organisations, and lots of organisations, of course, have spoken about the need to address racism. They've signed up to the Black Lives Matter agenda in one form or another. The important thing to do now is to find ways, and I think this is the kind of thing that Natalie's been talking about, to find ways of taking control of those agendas and making sure that they pursue them. Race and Health Observatory may be an opportunity. It's an independent organisation sitting within the NHS that grew out of the work that the NHS did to try and address inequalities underpinned by racism faced by NHS workers, but broadening its remit to talk about health more broadly and to talk about racism. Of course, it is sitting within an NHS structure, and so it partly depends upon how the NHS will respond to it, will accept the narrative. But for example, they did put out stuff around the COVID-19 vaccine prioritisation process, and they did say something to try and counter the narratives of vaccine hesitancy being about culture.
Yeah. Natalie, do you want to come in on that as well?
Yeah, so I guess this work is hard because there is so much resistance. And when we think about it's asking people to relinquish their power, essentially, and nobody really wants to do it, not when you have it. It feels good. But the little power that I sometimes feel when I'm sitting in a boardroom and somebody actually says, yes, you're right. But I think the learning from our work in Lambeth, and that was even before the kind of Black Lives Matter movement kind of gaining traction, last year. We've been working with Lambeth Council. They have published, they've now agreed to use an anti-racist lens on their public health approach to reduce violence that affects young people. We've worked with the Living Well Network Alliance, and communities have said, look, we need something that's kind of culturally appropriate in terms of helping us to navigate the health and care, the kind of mental health system. So they have essentially resourced us to co-design that with people in the community. And that has had zero interference from them. So that has been really positive. And Lambeth Together, which is an alliance of a number of alliances within the borough, they explicitly put in their terms of reference to address racism and other forms of oppression. So they've been quite explicit about that and have kind of set up an equalities group that is kind of focusing on trying to narrow the inequalities gaps for Black people. They agreed to that today, yay! So I think that it is possible. But I think when we're talking about institutional racism and systemic racism, we have to remember that we like to hide behind an institution, but it's actually people who uphold these institutions. And therefore it's a responsibility for each and every one of us to do what is within our power to address racism.
Yeah, and I think, it's true, we've seen a lot of people who work in smaller organisations really just addressing this head on, saying we need to do something about our organisation, or they're already working in an anti-racist way to improve the health of the people that they serve. But I just wonder, is there a danger of, Natalie, you were saying we want people to be able to deliver solutions for themselves. Is there a danger there where actually we're seeing lots of smaller groups and people locally or regionally doing the work for themselves, getting better outcomes for for their constituents in their area, but then this never really gets into mainstream policy? So I just wondered if you wanted to comment on that.
Yeah, I think that there is always that risk of you develop things, and in particular, Black-led organisations, the chronic underinvestment into voluntary sector organisations who are Black-led is a historic issue. And so there is, I think that this is where kind of partnership is kind of quite critical. But actually these partnerships being equitable ones, essentially, where power is shared. And I think that although within the work that we do at Black Thrive, we haven't necessarily always had that balance, but actually we have some great allies who really get this work and do what is necessary in order for us to at least start to change things. And I think if we were more likely to kind of work in that way, I think we would gain traction. But one of the biggest things that gets in the way are people's egos. It's like everybody wants, in the context of Lambeth in particular, everybody wants to be the one to save Black people. But actually, it's not about you, it's about the community and delivering what is best for the community. And so I think that is something that when we're working in the racial justice or the social justice space, that we need to be able to put our egos aside in order to ensure that we are investing in the communities who are most disproportionately impacted. Yeah,
thanks very much, Natalie. And I was going to just come to you, Parth, and think about, because of your role, the roles that you have, at IPPR, I always keep putting too many P's in there, sorry about that, and working also as an A&E doctor, thinking about, solutions at national levels to the impact of racism on health, and then thinking about what you're doing kind of individually in your work. How can we kind of bring together these solutions, from a policy perspective, to think about how to make sure these things do become mainstream? I know this is a really major question, but I just thought, in your unique kind of roles there that have come together, if you could provide a perspective.
Yeah, it's a really, really good question. I would say maybe the best way I would summarize that is that I think what we're talking about when we talk about racism and health, the problems are structural, and often the solutions proposed are on the individual, whereas in reality, the problems that are experienced are individual, and the solutions should be structural. It's flipped around. And as Natalie was saying, it's very much about power. And for example, Black Lives Matter has been mentioned a few times. Well, when people talk about that, they say, well, racism has gained a lot of momentum. Everyone says that so everyone focuses on the problem that Black Lives Matter brings up, but no one ever focuses on the solutions they propose. I'm not saying they have the right solutions. I'm saying they have solutions that are structural. They don't say that organizations need racism training. They don't come and say their solutions are a bit more radical. And I guess that's the point, and that was sort of the thing I was dwelling on in my presentation. In terms of what some of those structural solutions are, there are several, but I guess if you were trying to sort of pick one, and you were trying to get right down to the heart of power and politics, you would think about democratic representation and a form of democratic representation, and sort of how first past the post never really counts minority ethnic votes, and how minority ethnic votes are not politically popular. They don't really gain you that much, really. And how, if you wanted to shift that and start think more about sort of addressing structural racism, you would think a bit more about a different way of recognizing that. I'm not saying proportional representation is the way to do that. I'm just saying it's a question. Those are the sorts of conversations I think should be happening, and those are sort of the solutions you should be thinking about. But instead, what people do is they recognize the problem, and then the conversations about what to do about it are almost distracted into this individual information provision training approach, which I think sort of then takes us away from maybe some of the bigger things we need if the problem is structural, and the solution should probably be structural. Sorry,
I think that's something that we've all seen in our workplaces with unconscious bias training, but then absolute reluctance from senior leadership teams to actually tackle racism head on and talk about racism. So thanks very much to all of you for kind of just having that discussion. We're going to take questions from the audience now. So a few questions have come through on the chat. The first one I'm going to take is for James. A question asking about evidence of intersectionality and the effect of different things on health. So can you think about how ethnicity or racism, or precisely deprivation, gender and disability, how each of those relatively contribute to poor health? Can you comment on that?
Yeah, so there's something that Natalie put up when she was talking. She talked about systems of oppression. And I like to think of it that way around, rather than thinking about intersectionality in terms of listing the characteristics, is to think about systems of oppression and how systems of oppression operate jointly. And then what that means for the lives of groups of people, individuals within those groups. I think, Natalie, thank you for that. It gave me that that thought. So if we think about the ways in which patriarchy and racism operate jointly, then we can think about the ways in which gender shapes the experience of racism. So how men are racialized, how Black men are racialized differently from the way in which Black women are racialized, and then what that means in terms of their everyday encounters with institutions, but also what that means in terms of, and people, but also what that means in terms of their access to various forms of resources and the way in which they're culturally represented and so on. So I guess I try and think of it in those kind of ways, and then you can begin to introduce the ways in which other forms of oppression operate and introduce that. The other thing I don't like to do was to try and parcel out the different effects. And that's, I think Parth provided a very nice criticism of doing that. These aren't statistical confounders. These are things that are causally related to each other and then causally impact on the outcomes that we then see. So where you live is not an accident. It's driven at least in part by your ethnicity or race and those experiences, which then shapes other opportunities, the kind of work you get, again, and the kind of education you have. And these things are part of a causal chain. And I like to, again, go back to Natalie, the systems of oppression, and say the fundamental causes of these systems of oppression. So class, patriarchy, racism, and so on. These are the fundamental causes that we need to trace back to, rather than try and unpick the separate effects of the things that they set in train. Yeah.
Yeah, thanks, James. Natalie or Parth, either of you want to come in on that question?
Just very briefly, I'll say, yeah, I completely agree with that. I think, so when you think about systems of oppression or regimes of inequality, you can either pit them against each other, sort of oppression Olympics, it's quite a powerful political tool, or you could try and synergize them and bring together these systems of oppression, see what they share in common. They share quite a lot in common, and they certainly share common solutions. So I think it depends which way you want to cut it. And I think there's obvious political win or loss depending on which way you stand.
Yeah, thank you.
Yeah, and I would agree with Parth that, yeah, it's not intended, when we think about intersectionality, it's not about oppression Olympics. It's about us being able to understand how our social identities shape our experience. And that's certainly something that through my own research, I found really quite interesting, that, you know, my work is looking at Black communities and people who identified as mixed. And it's kind of quite interesting trying to see where there are commonalities in experiences, but also how your social identities then actually kind of create quite a different experience. And it's kind of through that, you're then able to see that actually there is no like singular Black community and a singular response to addressing, you know, challenges or building upon opportunities, that you can then, I suppose, develop more nuanced interventions that are more likely to sort of provide the solutions that we need, essentially.
Yeah, thank you. I'm going to take another question. I'm just paraphrasing here. Sorry, that first question was from Jonathan Tomlinson. Sorry not to acknowledge that at the beginning. So just another question that was actually sent to us before the session started, from a woman talking about how stress and bullying, racism in the workplace has led to poor mental health. And then Also talking about what was talked about by James in the increased risk of maternal mortality for Black women, and then how that then translates to people not wanting to take days off, not wanting because they're working in precarious jobs, and then because of this lack of trust, avoiding testing and wanting to avoid vaccinations because of not really having proper evidence or proper information about them. Can you, I'll give that to Natalie first, if that's okay. Someone really sharing their awful lived experience here. And could you comment on, I think it speaks to what we're already speaking about, how all these different things in people's lives come together to really create really quite awful life outcomes.
Yeah, and it's kind of like, I feel your pain. And I think that's the one joyous thing about my job is that, my team is a predominantly Black team. And so I no longer have to deal with that, the daily microaggressions. People don't like me because of my personality, not because of my race. But I think that it is a lot to deal with. And I don't think that employers really, or even health practitioners really take that on board in terms of the significant impact that your experiences of racism have on your well-being. And especially because it is often so covert that it's, again, very difficult to say, well, what is it that I said? Or what is it that I did? And it's almost like that sense of always feeling like you're being gaslighted. That is actually really, really destructive. And then it does play out in terms of how you're able to prioritize your self-care. If by taking the time out that you probably actually need, you're then going to be further victimized when you come back to work. And I know that my experience as a Black woman, always feeling like there is a higher expectation of me in terms of what I should be delivering. And to be perfectly honest, there really is. I was having a conversation earlier on today with somebody, and I was just even from a consultancy perspective, what I see some of my peers presenting as, this is what my offer would be to you. And I'd be like, oh, that's actually quite rubbish, really. I know full well that there is no way that I could go to a meeting and say, this is what I'm proposing, because it wouldn't be received in the same way. And I think that we have to have honest conversations about it and really kind of confront it head on. But then again, that can be really difficult, especially if you are Black in a white majority organisation, that you're very unlikely to have people who are going to back you.
Yeah, thank you, Natalie. James or Parth, do you want to comment on that?
Just very briefly, two things. I just quickly tried to find it, but I couldn't quickly. The code produced a series of graphic novels on racism at work. They're not a solution, but they do point to what the problem is and then where some of the support can be found. And it might be worth, if people are interested, it might be worth having a look at that. The other thing to say is about the accumulation of stress and how that impacts on our biology, and then how that impacts on our health. And all of the evidence shows that this takes place, and all of the evidence shows that the accumulation of racism across a life course impacts cumulatively on your health. There's a great American epidemiologist, public health person called Arlene Geronimus, who talks about weathering. You may have heard her talk on the David Harwood documentary. That constant drip, the drip on concrete, of water on concrete that gradually erodes it. And this is the accumulation of that stress, and something that we do need to take very, very seriously.
Yeah, thank you. I'm just going to move on to another question, if that's all right, Parth. I know you haven't commented on that one, but I'm going to come to you for this one first. So kind of two related questions, really. So one is about how people working in the NHS have been maybe doubly affected, because the ethnic minority people working in the NHS are more likely to be affected themselves by the virus, but then also would have caring responsibilities for or bereavements, in fact, of family members. So, you know, the question is really about how can we expect these NHS staff to recover from these things that they're going through? And then a related question about what medical training is given on racism to people, not just doctors, but people working within the NHS. So if you could take the two together, if that's all right.
Sure. I'll start with the second one. The answer is quite easy. It's very little. At least when I was at medical school, which wasn't an eternity ago, unless. I think again, I think there's probably going to be a groundswell of action to be shifting. There's lots of sort of student-led and crucially student-led initiatives to sort of change the medical curriculum, medical training. But the medical training makes no very explicit mention of how race interacts with health, and B is full of lots of racist tropes, is littered with them. But hopefully that's something we'll see shift soon, driven by students, and sort of young people in particular are far more liberal when it comes to race relations than older people have been in the past. On that second one, it's a really, really good point. There's this double whammy effect that minority ethnic staff face, particularly given that they're more likely to be low paid, particularly they're more likely to be in some of the most exposed jobs: porters, cleaners, domestic staff, caterers. They have the worst outcomes, more exposure risks and mortality rates of healthcare staff. And then they have caring responsibilities. I think there's almost 250,000 carers in the NHS. So it's that sort of clustering or concentration of inequality again that you see. In terms of what you can do about it, that's a great question. We've got something in the IPPR coming out on something like that towards the end of this month. There's no obvious answer. There's a few steps, sort of period of rest and respite, and how that can be built into the system. Flexible working is very much frowned upon unless you're very senior. It's changed a bit in the pandemic, but it's not easy. Pay is the obvious one. How much people get paid, sort of better alignment between contribution and reward is very much at the heart of some of those problems we've outlined. But particularly for low paid staff, there's quite a big disparity in terms of societal contribution and how much they're rewarded for it. But moreover, sort of changes to how medical training and progression operates is quite important. Minority ethnic staff are far more likely to say they've been discriminated by managers. They're far more likely to say they wish they had more opportunity to progress. The system's failing them. This isn't about individuals working hard enough. It's not about meritocracy. It's about the rules of the game. And I think some deeper thinking, which from my experience and my conversations with the NHS leadership and Health England Education, is something they're quite keen to do and talking quite vividly about. And James might know a bit more as to what the RHO are doing. But I think there's cause for optimism, at least in terms of the NHS structure itself.
Yeah, Natalie or James, do you want to comment on that?
Yeah, I mean, I would agree with everything that Parth said, but there is support out there, although generally, again, very underinvested in. But the UK Association for Black Psychologists, they deliver emotional emancipation circles, which are kind of Black-only healing spaces that focus on healing from experiences of anti-Black racism. And so whilst they're not necessarily a space to hold probably trauma linked to bereavement, but that's, you know, something that we're working with them around, kind of scaling and spreading that model of healing. And we're also working to develop a healing spaces offer to kind of test that. But again, that's kind of coming from the perspective of kind of Black communities. But I would say that, you know, most NHSs will have like an employee assistance program. And again, it may not necessarily be culturally appropriate, but, you know, I would, you know, suggest that people do actually try and access support through those services, and also obviously speaking to your GP in terms of being able to access support. But there are other voluntary organisations that are delivering support in communities. So Google may be your best friend, and kind of having a look for some of those organisations. And I know Ubele did a piece of work kind of trying to map provision, so it may be worth starting there.
Yeah. James, do you want to comment on that?
Well, just to restate Ubele, the Ubele Foundation have done a lot of work around bereavement. And it's something that came through the piece of work, Dharmi, that you and I did with Ubele, this question of bereavement. Yeah. The other thing to say is, I guess it may not be a medical school where learning around the impacts of racism is likely to happen, but certainly within the public health agenda, this is increasingly becoming increasingly important. So public health people taking this on, public health people are in local government reshifting what it's doing and thinking about. And so there has been some moves in Manchester, for example, in terms of thinking about the public sector leaders thinking about, talking about racism and how it might be addressed. So there are possibilities to be more optimistic. There are possibilities.
Yeah, thank you for that. And I think, you know, from kind of people I've been talking to as well, they're thinking about, well, within their workforce, thinking about how diverse that is. Obviously, that's not the solution, but also, you know, been speaking to an organisation that trains mental health social workers, and they're thinking about what their curriculum is like, how are they actually training them. So people maybe are paying more attention to training of people who work directly with those who are vulnerable. We've just got a few minutes left. I just wanted to ask one question about the vaccine, because I don't think we can kind of, I know you've mentioned the vaccine, but and we've talked about the problems with the delivery of the vaccine program. And, you know, we had the new modelling that came out, which made lots of new people from ethnic minority backgrounds shield, but then they didn't really get much advice on, you know, when they should get their vaccine. So I think kind of, you know, the vaccine program is running now. People are being vaccinated. You know, who is still really vulnerable and not getting this vaccine due to failures in getting the message out to them, not being contacted by their GP, etc.
But I don't know the full answer to that. But I guess I'll come to it in a minute. But for me, the crucial issue was when the vaccine was first rolled out and the most vulnerable were vaccinated, and the difficulty that people had in terms of accessing that vaccine. You know, go to the other side of Manchester to a big football stadium to get your vaccine. It's not appropriate. We do now see the movement of the vaccine into more local vaccine delivery into more local areas, into community centres and so on. Who's not getting vaccinated now? Who's not getting vaccinated? So we see still big regional disparities in terms of vaccine delivery, but also to get the vaccine, if you're not in the right age category, to get the vaccine, so if you're vulnerable, to get the vaccine, you have to somehow have a communication with your GP, who will then give you the link to go and get your vaccine, because you're too young, so you have to go for other reasons, you've got a chronic condition, whatever. If your communication with your GP is not fantastic, if your GP is not fantastic at communicating with you, then you just don't get it. So those people who are below the age, who have chronic conditions, and this is the shielding thing, you know, you're shielding, but your GP isn't working efficiently, appropriately, isn't communicating well, isn't accessible. Sorry, I've gone on more than I meant to.
And obviously, in the context of, you know, GPs are, you know, very slammed. They're very busy. The, you know, health professionals are working under these conditions too. So not to take away from what you're saying, James, but that is also a factor.
Maybe I was unsympathetic there.
Yeah. So, Parth or Natalie, do you want to comment on this final kind of point that we're going to have for the?
I don't know how qualified I am to kind of talk about the vaccine beyond my own personal experience as somebody who's on the shielded list. I think just in terms of just being able to have conversations about kind of concerns or like whether the vaccine is right for you, it's certainly been a barrier, as you're saying, like obviously people are working under COVID conditions, and therefore it's, you know, there are strains on the health system. But I think being able to get access to information to be able to make an informed decision, I think has been a bit of a challenge.
Yeah. Parth?
For me, I think sort of there are two different problems or different issues that sort of get conflated. There's vaccine attitudes or vaccine hesitancy, as you call it, and then there's vaccine coverage. And there are disparities in both. So vaccine coverage, who's actually been vaccinated, there are huge disparities by ethnic group. But then also when you look at vaccine confidence or vaccine hesitancy, there are disparities there being reported too. And that's the stuff that makes the front page of the news. It's sort of, and it's often the acronym BAME people don't want to get the vaccine. And then I guess the assumption that I think a lot of people fall into is that what's happening in people's attitudes is then leading to the disparities in the coverage. And there really isn't good evidence for that. And especially given how dynamic vaccine attitudes are. Yeah. We've got some work at UCL coming out on this week, but without giving too much away, we've got 4 in 5 people that were expressed sort of some hesitancy to vaccines in December, now either want it or have already had it 2 months later. And that's consistent across all ethnic groups, which is really, really interesting. Yet the debate will rage on, and disparities in vaccine coverage will rage on. There will always likely be ethnic disparities in vaccine coverage, but they won't be to do with vaccine hesitancy. They'll be to do with access and some of the stuff that James said about how do people get there, what's people's relationships like with GPs and with healthcare, what's the faith in healthcare, how historically have they interacted with healthcare, and in particular, I guess migration intersects with this quite strongly, and sort of people who don't have access to GPs, particularly vulnerable population, undocumented migrants. There's quite a lot of undocumented migrants in the UK. And sort of just announcing an amnesty doesn't really get through the hostile environment, which is the big barrier to people accessing healthcare in that group or in that population.
And I think that's a really important point, Parth, just to maybe end on, is shifting that conversation from vaccine hesitancy to vaccine coverage, which is, that is a lot of the work that we're trying to do in this area, which is shifting things from an individual level to a structural level. It's trying to move those conversations along and trying to move them along quickly enough so that they can have some kind of effect. So I'm going to wrap up the discussion now because we're at 6:31, so ran out of time. But what we've heard today from James, Natalie and Parth, and the ensuing discussion has really given us a lot to think about in this area. And I've really enjoyed listening to the discussion. And very many thanks to our audience for posing very interesting and challenging questions, and to the Stuart Hall Foundation for organising the event and hosting it. There's 2 more events planned this week, one tomorrow on employment and young people, and the last event on Friday, which will explore culture and cultural activism. And Alex Wheatle will be there. I was quite excited about that because I watched all the Steve McQueen's Small Acts films. So please register for the events on the Stuart Hall Foundation's website. And just one last thing is that we've heard a little bit about the Evidence for Equality National Survey evens that Bridget and James mentioned. I also work on that survey, so this is a little bit of a plug. So we really want ethnic minority and religious minority people to fill this survey in and tell us about what life has been like for them in the pandemic. And you'll see a slide at the end just giving you more information about that if you're interested, and you can share that with friends and family. Thanks again very much to everybody, and good night.
Thank you.